On behalf of the Western Montana Spiritual Development Council, I want to welcome you especially to this talk. If you don't know us, we're a very loose coalition of members and a few clergy. We began in 2005. We have members from about 20 plus faith communities in Missoula and surrounding areas. And our mission is really to encourage interfaith dialogue through bringing nationally known spiritual speakers to Missoula and sponsoring events for spiritual development education. We actually consider tonight an Ira's talk part of our mission. We meet fairly irregularly when somebody has a good idea, like, oh, why don't we invite Jim Wallace to come? Or why don't we invite Ira Bayock? And we have no funding except what we make on talks and DVDs. And this talk is open to everyone. It's not particularly for any religious persuasion, the spiritual, but not religious are most welcome. There's several housekeeping chores. First of all, MCAT is taping tonight. And we'll be filming the talk and discussion. If you don't wish your image to be shown, you can move to the back and get out of the range of Ron's camera. Otherwise, you can also watch it on broadcast. We want to especially thank Christ the King for granting us this beautiful space and making it possible to have us here. And for Missoula Valley Church for giving us some extra parking on Higgins, and many of you benefited from that. We're particularly grateful to them. We will have DVD copies, as I mentioned. You can purchase them sometime this summer. We're taking sign-ups downstairs. If you can check your cell phones now, that would be appreciated, except for medical pages. I guess we'll let you guys leave them on. Restrooms, the women's restroom is out the doors to the right and up a short flight of stairs. The men's is downstairs and to the left. And after the talk, and there will be a reception, we have lots of treats that we brought. There are tables downstairs for all of the providers who work with end-of-life care in Missoula. Ira's books are on sale, and he will be signing books as long as his arm holds out. So please come down. I think you'll want a copy of the book. I'm wondering how many of you are here by yourself. Don't have to raise your hands. And how many of you here with somebody who might be the person who will be named to carry out your wishes? Well, in case you're here by yourself, I would really like to encourage you to buy the book, because it's a little hard to go home from this talk and say, gee, dear, I just heard the best talk about dying and end-of-life care. It's not a conversation starter. So you can say, hi, dear, I just learned how to have the best care possible. And maybe they'll be a little more interested. Again, St. Patrick Hospital, Hospice of Missoula, Partners in Home Care Hospice, Aspen Hospice in the Bitterroot, Parish Nurses of Missoula, and the new Montana Leadership Training for Advanced Care Planning are listed in your program, and they're the ones who have information tables downstairs. And at the end, we'll explain if any of you have limited mobility how to get there. I now would like to introduce our speaker. Ira's lifetime of journeying with people who are dying has taught him that life is inherently spiritual, whether a person has religious beliefs or not, and never more so than when close to death. We saw this talk as an opportunity to share his and our belief that the end of life is to be honored, free of pain, and full of love, and that we as a community have a critical role to play in educating our members and ourselves. We know we all want the best care possible, but I have to tell you, since I just finished the book, I had a lot to learn about what that's going to mean for myself and my family. We all have stories about good dying and end of life, and we all probably carry stories when it has not gone so well. Ira writes that when any one person is sick, the family experiences the illness, and so do our friends, especially in the faith community. His book describes how all of us need to be involved in that care and to be cared for. For those of you who haven't worked with Ira before, and that's only half of the room, he came to Missoula in 1984 as an emergency room physician. He was already committed to hospice and palliative care, and he soon began organizing the first hospice program in Missoula. And as the hospice medical director, he convinced several national foundations to fund the Missoula Demonstration Project in 1996. That was a 10-year effort to study and improve end-of-life care in this community, for which he served as principal investigator. His work in Missoula gained him national prominence rather quickly. He was elected president of the American Academy of Hospice and Palliative Care in 1997, and he left Missoula in 2004 to become director of palliative medicine in Dartmouth-Hitchcock Medical Center and chair of palliative medicine now at Dartmouth Medical School. He's the author of several books. He reinforces Missoula's reputation as growing good writers, and his books have reshaped the national vision about end of life and taught us how to make that time a time of growth and grace rather than suffering and pain. The first book, Dying Well, was followed by the 4 things that matter most, which is used nationwide in hospice and pastoral counseling. And his new book, The Best Care Possible, tackles the crisis that surrounds serious illness and dying in America and how we need to transform care for the end of life. He's also co-authored with my husband and I the book, A Few Months to Live, Different Paths to Life's End, about end-of-life care in Missoula in the 90s. And the copies of the last 3 books are for sale after the talk downstairs. He has been honored by National Hospice, Cancer, Physician, and Catholic Chaplains organizations. He's been a featured guest on national television programs. And despite all these honors and national fame, we are certain that Ira's heart remains here in Missoula. So the council is giving him this photograph of Missoula and the Clark Fort. This is taken by our webmaster and poster wizard Karen Lowes, so that he will not forget Missoula or that a spirit runs through it. Our hope in sponsoring this talk is that the next terminal illness or death in our families and among our friends will be a better experience because we heard what Ira has to say, we bought his book or borrowed it from the library or our faith community. We found a way to start the conversation in our families about our wishes, and we actually filed an advance directive in the state registry. If you don't know how to do that, the tables downstairs will be glad to tell you. All of us want the best care possible. There is no one better than Ira Bayock to teach us how to do this.
Wow. So this is amazing. This is amazing. I've been traveling and speaking a lot and doing a lot of media and all that, and I'm more nervous now than I've been in months. Because, you know, because I'm really one of you, you know. We learned a lot of this stuff together. I wrote this book, darn fine book, A Few Months to Live, with about a research project with Roger and Jana, and Kay is here, Kay Norris, other principal investigator with MDP, and so many of you are part of my life and professional development. You know, authors write books and then they go on tour to sell their book. I gotta tell you, it's far more accurate to say that I wrote this book to give this talk. I really, I'm speaking with you, but also of you, or, you know, together with you, because we're all in this one together. I'm reminded being here and would like to actually dedicate this evening to my friend Frank Walker, physician, longtime physician in Missoula, who I came here to work with at Community Medical Center. Frank is over at St. Pat's now, working hard to survive after brain surgery. Please keep him in your thoughts, as he is in mine. My wife Ivana and I are once and future Missoulians. You ain't seen the last of us. We never gave up our home up the Rattlesnake, and we sneak back to town whenever we can, and we'll be back to town for good before too many years go by. But we've been busy. In a sense, this book, The Best Care Possible, is a story about what we've been doing since we left, which is building a program at, a leading academic medical center and trying to do all the stuff that we talked about and have promoted from Missoula, Montana in this East Coast Ivy League, cutting-edge medical center without skimping. That's what's really cool about it. We haven't, we've tried not to skimp at all. And the short story, in case you don't want to read the book, is it really works. Turns out it works really well. People like being well cared for, and doctors like their patients to be well cared for, and a health system really smiles broadly when people are really well cared for and quality is there. I want to acknowledge Yvonne, who, my name's on the cover of this book, but her fingerprints are on every single page, every line of every page. She was a part of the inception of this book and has been through every draft of every chapter, and many of those were many drafts of many chapters. So thanks for being here. I have some prepared remarks that I'm going to talk about in like 30 minutes or no more than 40 minutes, and then I'm going to shut up and dialogue, because that's really what I'm looking forward to, is taking questions and just talking about how we can do all this better. So I wrote this book because we make dying a lot harder than it has to be in America today. And I see so much suffering that is frankly avoidable or unnecessary. And I know, because we live it, that better care is possible. Not just a little bit better care, but much better care is possible. So I wrote the book because if you write a book, you have standing, at least for a few months, to sort of speak into the culture. Your op-eds get attention at the editorial offices of the newspapers. You get invited to be on, radio and TV. I've been on Fox and Friends. Go figure. I said yes immediately. Absolutely. And I've been on NPR, the Talk of the Nation, and so many local NPR affiliates, including here with Sally Mock. And it's really cool to be in dialogue. I've been doing this. You do these radio interviews, satellite interviews they call them, and you sit in your office and you do 15 or 20 interviews a day with various drive time radio or other news talk. And I've been all across the spectrum, from Christian radio to black hip hop and rap radio to right-wing news talk. Everybody I've talked with, frankly, endorses the idea that we want the best care possible for people through the end of life. It turns out the cultural chasm out there is not a chasm at all. It's a mirage. The vast majority of Americans stand on high common ground across, sort of feuding factions that look like we're polarized in America. I think we can get to yes and really dramatically change the way people are cared for through the end of life in America if we can actually engage in a conversation. If we can look at what the best programs and examples teach us, healthcare but also community-based programs, and then use that as an example of what's possible, we could just in less than a generation profoundly change the way we look at and approach late life and the very end of life and family caregiving. And we need to do that because, frankly, if we don't, we're going to leave to the next generation and to human civilization to come an eroded fabric of community. Because this stuff is really at the whoop and wharf of community life. Let me just say that we live in unprecedented times, and we're here and at this juncture of human civilization for the best of reasons, because we have unprecedented, incredible power to stave off death, to fight disease, to fight injuries. If you arrive, even severe trauma, if you arrive alive at an emergency department today, you're going to survive that trauma almost for sure. Could never say that, even in the middle of the 20th century. Nowadays, things like congestive heart failure are chronic illnesses. They used to kill people just like that. Kidney disease, of course, would kill people quickly. Liver disease. Cancers nowadays, if we can't cure them, and we cure about 60% of solid tumors these days, which is pretty good, but we've got a long way to go. But when we can't cure cancer, it often becomes a chronic illness that people live with sometimes for decades, but at least for months, and sometimes very well. So things are changed, and we need to celebrate all of the power that we have to prolong life and to live well with chronic illness. Nowadays, however, people come to the end of life often having 3 and 4 and 5 diagnoses that used to take us quite quickly. All of that, I think, by the way, is to be celebrated. The problem is we have yet to make even one person immortal. That's a problem. Because it makes it hard to know when to stop and when to shift goals, and because people are living longer with a higher burden of illness than ever before. Dying is hard, but these days, up to 20% of people die in ICUs, where very few people want to die. Over 70%, more like 80% of people on every survey that's been done say they want to be at home, surrounded by people they love, comfortable, clean, with their dignity preserved. But about 70% of people die in institutions, either nursing homes or hospitals, and those vary in proportion, but the sum of about 70% has been reasonably constant. People often, as I said, are in ICUs. Often the focus of care is all medical, and it's only on their diseases. Dying is hard, but it doesn't have to be this hard. I've been thinking a lot about the limits of our imagination these days. Imagination fails us on the one hand because when someone is seriously ill, someone we love, we can't imagine anything worse than that they might die. And yet it turns out there are things worse than having someone you love die. There's having someone you love die badly, suffering as he or she dies. And worse than that is later realizing that much of their suffering was unnecessary. On the other hand, our imagination fails us because we can't imagine anything possible that might be of any value associated with this time of life we call dying. And that's because many of us have seen people suffer and can't really think of somebody who's died who hasn't been consumed by suffering. Many physicians that I know fall into that category. But in fact, there are things of value associated with this time of life. When we medical people are doing the basics of controlling people's discomfort and managing their pain and their breathlessness and their GI upset and then, all of that, often these times have profound value for patients, people who are ill and their families. And that's part of the human endowment as well, that we have to, as a society, preserve and promote. That's why stories are so important. Because without the stories that can help us imagine first how bad things might be, but also how good things could be, it's hard to sort of move in a direction that's desirable. And I think that's part of the problem. We don't know what success would look like when we think about these times of life of serious illness, caring for someone with Alzheimer's disease, or caring for somebody who's hospitalized now and has serious infections and has been in the hospital for 2 or 3 weeks and is getting worse, not better, or is just languishing and not getting better. What does success look like now? The phrase I find I use most often when I meet patients is, I want to give you the best care possible. That's what we all want as physicians, nurses, social workers, chaplains. That's what we want for the people we love. That's what we want for the people in our families who we love. One size doesn't fit all, of course. And so, I know that that's the one thing everybody agrees with, but then at least it gives me sort of the phrase creates a vessel into which we can begin to pour meaning. And I just, I usually say, I need to know more about who you are as a person. To know, what the best care would look like now for you. And we need to keep exploring that as we go forward, whether you get better with treatment of this illness or whether you don't. What does the best care look like for you? That involves more than just treatments for your disease. That includes, attention to your well-being, to your comfort and quality of life, and to your family support. These days, what I do in palliative care, and what ought to be available to all people who are seriously ill, is this notion of shared decision-making. People hear that phrase? It's still sort of new. You know about informed consent, right? So you sign, for an operation or some procedure, and you're fully informed about the potential benefits and the risks. And shared decision-making is sort of the proper process to get to informed consent. But it's reasonably new. When I was growing up in the 1950s and 60s, shared decision-making occurred when a doctor shared his decisions with you. We've come a long way from that. Nowadays, doctors are supposed to partner with patients, find out what the patient's values and preferences are, and then help the patient by applying those values and preferences to the particularity of the person's condition, available treatment options to achieve, achievable healthcare outcomes. Okay? Individual values and preferences applied to the particular medical condition in service of achievable healthcare outcomes. That's not terribly esoteric, but a meticulous process that ought to go on multiple times a day in every, physician's practice. Certainly when somebody is critically ill. So the best care possible takes a process, takes this notion of preparation, as Jana was saying. National Healthcare Decisions Day is coming up the 16th, right after, we deal with taxes, we can deal with death. But it's a good time to sit down and have the conversation. At very least, giving the people that you trust formal permission to speak for you. That's part of it. It doesn't just happen, I hope I get a good death. That doesn't just happen. It takes some preparation. I have an advance directive, not so much even for me as for my wife and my daughters, who I know if I'm in a car accident later tonight, have a serious head injury, they're going to struggle with treatment, decisions about my treatment and care. I can't stop that. But I can give them clear authority to speak for me so that no ethics committee or judge needs to get involved. And I can give them a sense of what I would want so that perhaps the decisions they make or struggle with will be slightly less heavy, slightly less burdensome. The best care possible takes preparation. It takes doctors who, not only understand the physiology and pharmacology of disease, understand the ethics of decision-making, the process of shared decision-making, doctors who can actually communicate clearly, and doctors who enjoy working with people. I work in a place nowadays where I know very good doctors, really brilliant, committed, high-valued people who are more comfortable doing research than working with seriously ill people. I value their contributions, but if someone I love is seriously ill, I want a doctor who actually enjoys doing this, who derives some satisfaction from it, doesn't see it as a chore. And doctors have to work in a health system that's actually functional. Oy vey. We got a problem with that. I mean, no, I'm not pointing fingers, and it's frankly nobody's fault, but our healthcare system is really not very functional. Our healthcare system is really a disease treatment system in America. And it's a powerful one, and one that, again, I applaud. I love the fact that we can treat disease and keep people alive quite long, and sometimes cure people that have just dramatically serious illness. I still hang out in ICUs a lot. That's where we do a lot of our consults. And I just applaud and celebrate the power that we have in this 21st century. But we're not so good at treating people with illness, their well-being, their feelings, and their emotional, social, and spiritual well-being, or their family support. 30% of families who've had a loved one in an ICU have verifiable post-traumatic stress disorder. Think about that. You know, family caregiving family caregiving has become its own diagnosis. I mean, it's really a source of significant stress. And it takes a family, the best care possible also